These are the two important examples for the medium vessel vasculitis. There are other examples as well, but I'm only focusing on the main. You can see that the bridge of the nose is depressed here, so this can commonly happen in Wegener's granulomatosis. Testicular pain is a common feature because the testicular vessels can be commonly affected in cases of the PAN. Now vasculitis. Among the vasculitis, always try to write down a classification. Mainly three types. So one is the large vessel vasculitis. Then the other one is the medium vessel vasculitis. And then the small vessel vasculitis. So most of the vasculitis examples will be belonging to the small vessel vasculitis. So we'll start with the large vessels because these are relatively easier to remember. Number one is the giant cell arteritis or the temporal arteritis. And number two is tachysoarteritis. These two are mainly important, large vessel vasculitis. And for the medium vessel vasculitis, examples are polyarteritis nodosa or the PAN. And the second one would be Henoch-Schloelen-Parpia or HSP. These are the two important examples for the medium vessel vasculitis. There are other examples as well, but I'm only focusing on the main, examples. Also, sometimes cryoglobulinemia. Cryoglobulinemia, it tends to cause both medium to small vessel vasculitis, but more commonly medium vessel vasculitis is seen in cryoglobulinemia. In the small vessel vasculitis, we will discuss about the Wegener's granulomatosis or the granulomatosis with polyangiitis, also known as the GPA. Then we will also discuss about the Churg-Strauss syndrome, also known as the eosinophilic granulomatosis with polyangiitis. Then we have the microscopic polyangiitis. So these are the main three examples. Apart from that, we have already discussed about the Behçet syndrome. Mainly, these are the main examples, like the Wegener's, Churg-Strauss, microscopic polyangiitis, and Behçet syndrome. So these are main examples of the vasculitis. Now we will discuss here, starting with the Wegener's granulomatosis or GPA. Wegener's is not the term that they use anymore, so be very careful. It's better to call it GPA. It's an autoimmune condition associated with necrotizing granulomatous vasculitis affecting both the upper and the lower respiratory tract airways. And one of the striking features of Wegener's is, let's see if there is any nasal picture that is given. I think in the first class I mentioned that I faced 3 questions coming from the Wegener's or the GPA. So in paper 1 I had 2 questions, and the second paper I had 1 question coming from this particular portion. So this is that much important because not only this can be a question coming from the rheumatological section, but this is an important question that can come from the respiratory system. It's an important question that can come from the renal medicine or the nephrology system as well. So features are mainly upper respiratory tract. It can cause epistaxis, sinusitis, nasal crusting, and nasal deformity. That is saddle-shaped nose in the long run. The patient has undergone rhinoplasty here, but you can see that the bridge of the nose is depressed here. So this can commonly happen in Wegener's granulomatosis. Lower respiratory tract infection, it can lead to recurrent pneumonia, dyspnea, chest infection, or hemoptysis due to alveolar pulmonary hemorrhage basically. From the vasculitis, the vessels will be ruptured and the blood will come out within the lung parenchyma and then will be coughed out subsequently. Rapidly progressive glomerulonephritis or RPGN. So this is one of the causes, important causes of the glomerulonephritis. It causes post-immune and it can affect in 80% of the patients. And saddle-shaped nose deformity, which I've already mentioned, it can also cause, because the name is vasculitis, so the blood vessel is everywhere. So that's why multi-system presentation can take place, like either in the form of skin rash, joint pain. Sometimes it can cause some cranial nerve palsies as well. It can also cause sensory neural deafness if it involves the 8th cranial nerve, and eye involvement such as proptosis, cranial nerve lesions that can be commonly seen. I had a patient who had 5th, 6th, 7th and 8th cranial nerve lesion bilaterally, and at the same time patient had saddle nose deformity, and on examination the patient also, he was a very stereotypical case of the Wegener's granulomatosis. Unfortunately his hearing damage that took place, it was permanent. So in this case, investigations are C-ANCA positive, and that is in more than 90% cases. You can go for a chest X-ray. If the patient complains of hemoptysis, you can go for lung biopsy. If the patient complains of hematuria or proteinuria, in that case, you can go for a renal biopsy. And in this biopsy, most of the time, cavitating lesion and at the same time, necrotizing granulomas are seen. Treatment is basically in the form of steroid, cyclophosphamide, plasma exchange. Median prognosis is quite bad. Median survival is only 8 to 9 years. So let's read out a question that way you will be able to answer more and more questions related to this. So history of chronic sinusitis, that is already indicative of upper respiratory tract infection with shortness of breath, that is lower respiratory tract infection. Initial investigation showing low hemoglobin, platelet and WBC count. Platelet is normal, but WBC count is slightly raised. ESR is high, serum urea is increased, creatinine is also increased. Urine dipstick is showing blood 3+. So among all this information, there is no mention of any neuropathy or neurological symptoms here yet, and patient's eosinophil count is not mentioned here at the same time, and there is no background asthma. So that's why Churg-Strauss is ruled out. Then it is a case of Wegener's. As you can see, there is mention of both upper and lower respiratory tract and renal involvement. And for the Henoch-Schleuden purpura, usually from the buttock and the lower extremity distribution, there is purpuric or palpable vasculitic skin rash. That's a more common finding, and abdominal pain, hematuria, these are relatively common. So polyarteritis nodosa or PAN, so this is a medium vessel vasculitis, and necrotizing inflammation leads to aneurysm formation here. So in the Wegener's granulomatosis, it leads to necrotizing granuloma formation, and here there is necrotizing inflammation leading to aneurysm formation. PAN is more common in the middle-aged men, and this is often associated with hepatitis B infection. So that is actually your clue. So if there is any mention of concomitant or prior hepatitis B virus, and now the patient has multi-system complaints, in that case, do think about polyarteritis nodosa. And polyarteritis nodosa has like couple of distinct feature that makes it like unique diagnosis. For example, in the intestine, because of this, like necrotizing inflammation in the intestinal vessels, it can lead to mesenteric ischemia, and with mesenteric ischemia, the pain is very distinct. That is, even with a small amount of food or maybe even with glasses of water, patient will scream out of pain. So that much intense abdominal pain takes place, even with slight, stomach distension or intestinal distension. And subsequently, this mesenteric ischemia can lead to gangrenous gut. And in a male, testicular pain is a common feature because the testicular vessels can be commonly affected in cases of the PAN. And in the skin, sometimes the livido reticularis type of skin lesion can be seen in polyarteritis nodosa. So there are features that will, at least 3 of the 10 ACR criteria should be met when a radiographic or pathological diagnosis of vasculitis is made. So what are these features? That is weight loss of more 4 kg or more, livido reticularis, testicular pain or tenderness, myalgia or leg weakness or tenderness, mononeuropathy or polyneuropathy, diastolic blood pressure greater than 90 mm mercury, so hypertension basically, elevated blood urine nitrogen or creatinine level unrelated to dehydration or obstruction, so that is renal impairment. But hematuria is among all these vasculitis, polyarteritis nodosa, it's usually not associated with hematuria or glomerulonephritis. Interstitial nephritis is a bit more common feature, which is why you'll see renal impairment is present, but proteinuria, hematuria, these are relatively less common in PAN. And presence of hepatitis B surface antigen or antibody in the serum, and arteriogram demonstrates aneurysm or occlusion of the visceral arteries. So, which I've already mentioned, like the mesenteric ischemia, testicular vessels, these are all visceral arteries. Biopsy of the small or medium-sized artery containing polymorphonuclear neutrophil, that is usually neutrophilic infiltration. So this is the livido reticularis type of skin lesion in the lower limbs. And this is actually an angiogram with polyarteritis nodosa. Both kidneys demonstrate beading and numerous microaneurysm affecting the intrarenal vessels. So these are the beading here you can see, and these are basically the microaneurysms. These are the beadings. So in case of the PAN, Remember that C-ANCA is almost always positive in Wegener's, and P-ANCA will be positive in rest of the types of vasculitis. So cytoplasmic antineutrophil cytoplasmic antibodies, these are least recognized ANCA that is associated with the polyarteritis nodosa. Diastolic blood pressure should be more than 90. Mononeuropathy or polyneuropathy should be present. Pyrexia or fever, weight loss, that can present as well. Renal failure, it can happen. So polyarteritis nodosa, least recognized association is the C-ANCA. Here you can see question number 127. A 54-year-old male presents with abdominal pain, testicular pain, weight loss, left foot drop, that is indicative of common perineal nerve palsy, and livedo reticularis. You suspect a diagnosis of polyarteritis nodosa and request a full autoantibody screening. From the options given below, what are the most likely to see when the results of this autoantibody screen returns if the diagnosis is polyarteritis nodosa? Is it positive anti-CCP, positive rheumatoid factor, anti-RNP? No autoantibody is likely to be positive in anti-Smith. The answer is no autoantibody is likely to be positive. Rather, ANCA will be positive, mainly P-ANCA and biopsy. These are the investigation modality.